So I'm Weiqin, I'm one of the heart failure cardiologists from National University Heart Centre Singapore. So I'm very happy to be here because this is truly a national effort to raise awareness of this condition, transthyretin cardiac amyloidosis. Most of us would not have heard of this disease. In fact, many doctors are very unfamiliar with this condition as well. Why is it important? How does it affect the individual? I think this is what we are trying to cover today, to raise awareness, to let people know that, hey, this condition exists, it's a serious condition, and we need to look for it, treat early to improve the outcomes for patients. So very, very important. So today we are going to cover a few topics. So we first speak the same language, we understand what is cardiac amyloidosis, what is transthyretin cardiac amyloidosis. Then we find out what is the symptoms that patients usually have when they have this condition. How do doctors suspect that patients have this condition, and how do we diagnose this condition? And after being diagnosed with transthyretin amyloidosis, what is the treatment? What is currently available to help patients deal with this condition? And lastly, not only to the patient, how does this condition affect my family members? Is it a hereditary problem? So we will cover all these topics over the next 20 minutes. So as an introduction, we first must understand what exactly is this condition. So amyloidosis, let's break down the term to individual words. So we first understand what is amyloidosis first. Amyloidosis just means a protein folding disorder. There are many proteins, tens of thousands of different kinds of proteins produced by our body floating around in our bloodstream. For reasons not completely understood to us, some proteins can denature, dissociate, and become insoluble fibrils. So these normal proteins under the some condition, under the right condition, can actually turn into these long strings of insoluble long strings of proteins, and when they go into various organs, they cause dysfunction, disease of the organs. So that is called amyloidosis. So as I mentioned, there are many proteins in the body, and many of them have been shown to have potential of becoming amyloid proteins. Some common amyloid proteins you might have heard would be amyloid deposits in the brain causing Alzheimer's disease. Some amyloid proteins can go to the kidney and cause kidney failure. Many amyloid proteins can go to the joints and ligaments to cause orthopedic problems. But luckily for cardiologists, for us, cardiologists are very simple people. We want to simplify things. So luckily for us, there are only two kinds of amyloid proteins that can cause heart problem. So one of them is this thing called AL amyloidosis, and the second one is the focus of our talk, TTR amyloidosis. But there is no amyloidosis, cardiac amyloidosis talk that can be complete without mentioning this condition, AL amyloidosis. What is AL? AL means light chain amyloidosis. Light chain are actually components of the antibodies produced by our bone marrow. So our bone marrow is a very important organ. It produces antibodies to fight diseases. And these antibodies come from a certain kind of cells in the bone marrow called the plasma cell. So when there's excessive plasma cell and the plasma cell keep producing a lot of antibodies, these antibodies can actually aggregate and form amyloid. This really comes from the bone marrow problem. It's a bone marrow problem due to excess production of plasma cell, unregulated production of plasma cell. If you think about it, this is actually a bone cancer. It's very similar. It behaves exactly like a cancer, but this cancer in inverted commas is this plasma cell that produces abnormal proteins, and when the body is flooded with all these proteins, then the proteins will go to different parts of the organ systems and cause problem. And one of the organ systems that can be affected by this protein is the heart. Okay, so roughly about 50 to 60% of all cardiac amyloid is caused by this light chain. All right, so this light chain, very important. Every time we see someone we suspect of amyloid, we must think whether it's light chain, whether it's like a low-grade cancer. The disease that we are interested in today is this thing called transthyretin cardiac amyloidosis. Transthyretin, as with all other proteins, is a normal protein that is produced by the liver and is floating around the body, performing its function as a transporter protein. It transports important hormones like thyroid hormones, vitamin A to all the systems around the body. And in some cases, which we don't really understand why, this transthyretin, which has 4 units, 4 subunits coming together to form a functional transthyretin protein, it actually breaks down, and this single units, from 4 units, it breaks down to 1 unit, and these 1 units, they actually like a Lego, they just come together and become amyloid fibrils. How does that happen? Why does that happen? Sometimes we do not know. But there are a group of patients, they have an inherent unstable transthyretin because of a gene mutation. This group of patients potentially can pass down this problem to the family members. The other group of patients who do not have gene mutations, they are actually called the wild type patients. Because of aging, because of some external environment factors, this transthyretin breaks down and becomes amyloid. We do not know the exact reason first. So as I said just now, hereditary is the group of patients who have transthyretin amyloidosis because their protein produced by the liver is unstable because of a DNA mutation. And these proteins will dissociate and become amyloid and manifest as heart failure and manifest as neural problems, which I'll elaborate on later. The second group are some patients who are more advanced in age. Because of aging and some other external factors, the transthyretin breaks down and then become amyloid fibrils. This group of patients, we can detect the gene mutation on DNA testing. This group of patients have essentially normal DNA. So that's the difference. All right. So yeah, we sort of understand this pretty uncommon and seldom talked of disease, transthyretin amyloidosis. So it's uncommon, then why is it important? Why are we spending our Sunday here listening to this symposium on why we need to learn about attrcm then? So first of all, we need to figure out how big a problem it is, right? If it is only affecting 1 or 2 Singaporeans out of the whole island, then maybe not so much importance. But actually, it is far more common than we thought, and it has been neglected for many, many years because we don't understand it well, and we don't know how to treat this condition very well. So last time, there was a study done in very elderly patients who pass away from other reasons, and they went to take random sample of their heart muscle tissue, and they found that in patients in individuals who are very, very old, more than 85 years old, 25% of these individuals actually they have some evidence of amyloid in their heart. So that begs the question whether this is a normal aging process. We don't understand it, but all these patients do not have, at the point of death, diagnosed amyloidosis. So last time they think that this is an old man's problem, elderly problem, but increasingly we are seeing it in younger and younger patients. That's because we are screening earlier and we are more in tune with this condition. So we are starting to see some patients in their 50s, 60s being diagnosed with this cardiac amyloidosis. In Singapore, I would hazard a guess, a ballpark figure of the number of patients can range somewhere between 150 to 200 patients, from the latest statistics we have. So it is a common enough problem for us to take it seriously, to consolidate our resources on a national level to try to tackle this problem, and that's why we are all here today. So knowing how common it is, now we need to know what are the symptoms that actually worries doctors, and it should worry everyone to maybe suspect and consider this condition. So in wild type, which is the old person's disease, transthyretin amyloidosis, most patients develop heart failure, heart problems, and they have also some long-standing bone problems, ligament problems, such as carpal tunnel syndrome, back pain, and things like that. Those people with hereditary problems, hereditary DNA abnormalities causing the transthyretin amyloidosis, they have a little bit more system involved, such as nerve problems, muscle weakness, muscle degeneration, eye issues, kidney issues. This is more systemic in nature compared to those with wild type or aging related amyloidosis. So I just put this light chain thing for completion. Light chain is a more aggressive disease. It is, as I said, sort of like a low-grade bone marrow cancer. It affects every organ around the body as well, which includes kidneys, includes the intestines, include the nerve system, as well as eye, and of course the heart. Okay, but now today we are focusing on this group. ATTR wild type, meaning no mutation, or the variant, the mutation kind of transthyretin amyloidosis. So to recap, some of the common symptoms that patients can present with would be postural giddiness. When they get up from a lying position, when they stand up, they feel dizzy, they feel like they are going to black out. And if we actually check their blood pressure, there's a significant drop of blood pressure from the lying to a standing blood pressure. So this is a common symptom that patients actually present with. Many of my patients actually come to see me because of this thing that the primary care physicians notice. Maybe a 70-year-old man has had high blood pressure for the past 30-40 years of his life. Then suddenly, he's increasingly unable to tolerate his blood pressure medications. His blood pressure control, in inverted commas, have improved over the years. So that is a very strange phenomenon, because as we get older, blood pressure is a one-way street. It will only get higher. For the blood pressure to slowly drop as the patient gets older is something quite abnormal, and now we know to pay more attention about this scenario, and we will often check carefully, check the nerve function and check the heart condition. So this is quite important, especially for people who have been taking long-term blood pressure medication. It's very, very strange that you are suddenly cured of blood pressure heart problem when you get older. As I mentioned just now, there are some orthopedic conditions or bony conditions that's associated with transthyretin amyloidosis. Carpal tunnel syndrome, which is a very common condition when you have tingling sensation of the hands because of the nerve compression at the level of the wrist. So this usually would warrant a surgery to take out the tissue compressing on the nerve. So that is because of amyloid deposits on the ligament. Then it compresses on the nerve, causing numbness in the fingers. Same thing can happen with the spine. There are lots of ligaments around the spine. If there is amyloid infiltration of the ligaments, it can actually compress on the spine and cause same thing, numbness, pain down the spine, sciatica, these kind of problems. There are some patients who have very, very low heartbeat, and it is because of the aging of the wires of the heart. The wires of the heart, in a sense, controls the speed of the heartbeat, how the heart beats. And if there's degeneration without very clear cause, and especially if it's associated with a very, very thick heart, then we must start to think whether this is because of abnormal proteins infiltrating the heart. And of course, many patients also present with fluid retention, volume retention, or what we call heart failure. So as I alluded to just now, actually carpal tunnel syndrome, of course, is a common condition amongst people, especially nowadays, and we do a lot of computer work, or people who do a lot of hand activities. They can have carpal tunnel syndrome. But there are many studies from not only US, Western population, but also in Japan. Actually, they find that carpal tunnel syndrome is like a warning sign, might be an early warning sign for the subsequent diagnosis of transthyretin cardiac amyloidosis. So if they go for carpal tunnel surgery, if they just take some samples and they go and stain, actually there are significant number of patients with abnormal amyloid deposits in the carpal tunnel tissue. So it's an interesting observation, and it can precede the onset of heart symptoms by up to 10-15 years. So many people, before they are being diagnosed with cardiac amyloidosis, I actually ask them, have you had any tingling feeling in your hand before? Have you undergone carpal tunnel surgery before? Actually, a significant proportion of my patients actually had the same problem before, just like what was being reported in Japan and the US. So something that we need to take note of. Why is this important? Because we know that in patients with cardiac amyloidosis, not only they have water retention problem, there are symptoms of breathlessness, they actually have impaired lifespan. So this is not a benign condition, you just take blood pressure medication and you can live a very long life with it. No, this is actually quite a serious condition, and many patients, in general, we say many patients who are diagnosed with this cardiac amyloidosis, the transthyretin cardiac amyloidosis, their life expectancy after diagnosis is about 3 to 4 years. There's a very simple staging system that we use. We use two very commonly used, at least in Singapore, commonly used blood test markers. Number one is a protein that is produced by the heart called the NT-proBNP, and the second one is just a measure of your kidney function. This is done very, very routinely in the cardiac clinics. Just by using these two markers, we can stage this amyloid cardiomyopathy into stage 1, stage 2, stage 3, just like cancer. Those people with very abnormal, these two markers being very abnormal, they are at very high risk of dying. And if you follow this green color graph curve, which is stage 3, at 5 years, 60 months, 75% of them are dead already. So this is a serious condition. 5 years survival rate is only 25%. That is worse than most cancers that we know of. You think of breast cancer, the survival rate is 80%, 90% after 5 years. This is 25%. But of course, if we pick it up early, the two blood markers are pretty low, then the survival at 5 years is slightly more than 50%, which is also very serious. Half the people, more than half the people that you diagnose with cardiac amyloidosis today will not be around in 5 years' time. This is, of course, before the era of available treatment. Nowadays, we have some treatment available, and I'll touch on that later. So how do we diagnose? Well, of course, we always do ECG when we see patients with cardiac problems. ECG can give us a clue, but it's not always the most accurate. It can be very, very non-specific. But most of the time, we start to suspect patients with cardiac amyloidosis after we do an echocardiogram. Echocardiogram is just a simple ultrasound of the heart. It is a probe that we use to shoot ultrasound rays into the heart and then form pictures of the heart. It's exactly the same technology that we use, and pregnant women, we scan the tummy for babies. It's the same thing. It's the same machine. We just shift it upwards and scan the heart. And it can show us a shape, size, function of the heart. And when you have abnormal proteins going into the heart, it actually causes the heart muscle to look very, very thick. See? So this is a normal heart muscle. It's about 1 cm. This patient is about 2.5 centimeters. It's much thicker than a normal heart muscle. So this is when we suspect amyloidosis. At this point in time, we need to confirm the diagnosis. 5-10 years ago, the only way to confirm diagnosis is put a tube into the heart and bite out some muscle tissue, but this is an invasive procedure, and this often is not very well accepted by our elderly patients. They don't want to have anything invasive, they don't want to put lines into them, and this is of course limited by expertise. So that gave us problems in the past to diagnose this condition. But nowadays there's a very simple nuclear scan. We just inject a dye into the body, make the patient lie down and scan the patient, and if this thing lights up on the nuclear scan, then we can confirm the diagnosis of transthyretin cardiac amyloidosis. It helps us in making a diagnosis. Everything is a lot faster nowadays. Then of course, how do we manage this condition? There's general management and there's disease-specific management. General management means if the patient is breathless, they have fluid retention, water overload, then you give them water pills to help them clear the water, pass out the extra fluid. If they have slow heart rate, fast heart rate, we manage the heart rate to make sure that it's not too fast, too slow. So these are the general cardiology management that we can do for the patient. And of course, advice on exercise and fluid restriction, all these kind of things. But increasingly, there are more and more medications to treat this condition. If we remember, going back to the initial slides, we know that this transthyretin protein is produced by the liver. Then in the body, it somehow breaks down and comes together again in this insoluble protein, amyloid protein. So at each stage, we can potentially stop the disease. For example, we can target at the liver, stop the liver from producing, close down the factory, no more transthyretin is formed. Or we can target the initial protein, make sure it doesn't break down to form amyloid. Last step we can do is, in patients who already has amyloid, we can introduce a medication to clear this amyloid. So many drugs are under development, but currently the only available drug that we have to treat this condition is this thing called tafamidis. Tafamidis is a medication that stabilizes this protein to avoid the breakdown into single units. It keeps the protein in the normal 4-unit kind of setting and prevents disease progression. And this has been shown in big studies to help patients live longer, feel better. So this is available now, and it has really helped us manage patients and change the trajectory of the disease for many patients. Lastly, a few slides on how it can affect my family. As I mentioned, there are some patients with a hereditary form of amyloidosis, and this hereditary form can affect 50% of all offsprings for the patient. So let's say this is the DNA of the patient, and the orange color one is the abnormal DNA. So for every child, there's a 50%. If you look at this, out of 4 people, two of the offspring gets the disease because of this inheritance pattern. So I always tell my patient, your child, every single child has a 50% chance of getting the same condition as you. It's just like flipping a coin. So it's very good for every single child to go for gene testing or at least regular ECG screening just to make sure he has not inherited this condition. So very important. And what is gene testing? Gene testing is not so scary. It's actually a simple blood test. This blood test is sent to a lab where they analyze the DNA, and if they find the DNA mutation that can account for this genetic condition, amyloidosis, then they'll report this as this is the culprit gene causing this condition. Then they use this template to go and check the rest of the family to see whether they carry the gene. If they carry the gene, then of course we will need to follow up these patients and make sure that they do not, once they develop the disease, we catch them early and treat early. For family members who do not carry the mutation, then they don't even need to think about it. They will not be affected by it for the rest of their life. So that's the use of this gene testing. And gene therapy is a very new field and it's very, very exciting. We have a new technique, CRISPR-Cas9, which is essentially using a protein to go and cut off the affected gene so that the liver does not produce any more transthyretin. This technology has been used in, if you heard the news, there's a recent, past few years, there was a transplant, a pig heart transplanted in a human heart. They use the same technology to cut away all the pig DNA so that when it transplants into a human, the human will not reject the pig heart. So this technology is now being used to treat amyloid. They go and cut away the DNA segment of the transthyretin gene so that the liver does not produce any more transthyretin. And we see that over a very long period, about a year, this one jet to clear the DNA segment actually produces after that the liver actually produces very, very low levels of transthyretin, and we believe that this will prevent disease progression in the future. Singapore is part of this trial and we are enrolling patients to help us understand the use of this drug better. So very, very exciting times ahead. So in conclusion, we have learned that cardiac amyloidosis is uncommon, but it has been long neglected, and it is time for us to sit up and put more focus and have more attention on this condition. Transthyretin amyloidosis is one kind of cardiac amyloidosis, the other being light chain. It can be due to aging problem, or it can be due to an inherent DNA mutation causing unstable transthyretin protein. It now can be diagnosed using scans instead of going in to do a cardiac biopsy, so it's much easier to diagnose. We know that patients with transthyretin cardiac amyloidosis, they are often very symptomatic. They have lots of heart failure symptoms, they have water retention, they have low blood pressure, and it's a very debilitating condition, and it severely impairs the life expectancy of these patients. And luckily for us now, there are some medications which can protect the patients and prevent disease progression, prolonging life. The currently only available medication for us in Singapore is this compound called tafamidis, and recently it has government subsidy, so it's more accessible to most of my patients now. So for the last 2 slides, I would like to use this time to thank the team of doctors and allied health professionals who have been helping me manage my amyloid patients. Thank you very much. Thanks.